Our speaker, next one, plenary lecture is in fact, it's an EAU lecture from the European Association of Urology. And the lecturer, I wish to briefly introduce, he is Christopher R. Chapple. He is in fact the Secretary General of the European Association of Urology. He leads 18,000 urologists in all Europe. And he's a consultant urological surgeon specializing in functional and reconstructive urology at the Royal Hallamshire Hospital. And he has published over 850 publications in peer-reviewed journals, authored 18 textbooks, and written 38 chapters in urology-related books. And may I invite Professor Chapple to deliver the EAU lecture.
Ladies and gentlemen, thank you very much for giving me this opportunity. I'm a functional urologist, so I'm hopefully not too dysfunctional. And certainly in this context, I deal with both medical and surgical issues relating to the disorders of the urinary tract. My background was, I had a particular interest in pharmacology, which is very relevant in urology, urodynamics, which is the function, and then it's a surgical reconstruction. Now, the subject of this talk is that of tissue engineering, which is very, very trendy at the moment, isn't it? Very topical. These are my conflicts relating to pharmacology. And this is an EAU lecture, and the EAU, as I mentioned last night, is an organization like yours, which is committed to looking at the best evidence to deliver the best care to our patients. Now, tissue engineering or regenerative medicine is something which is very topical. Everybody's looking at this and trying to do it, but really let's look at it objectively. What are we trying to do? Well, basically, it's synonymous with trying to produce new tissue and the use of a combination of cells, engineering techniques in the laboratory, and a matrix, which is actually what the cells grow on. And it involves an interdisciplinary team because it's not just the histology, the histopathology, but also colleagues dealing with producing a matrix and people from cell biology. So whilst it seems very simple, if you look at any of the tissues that we have, and we're all made out of billions of cells, and remember, a single cell, the biggest cell in the world is the ostrich egg. Basically, those cells can either be ones which are actually formed into a tissue or pluripotential. At the end of the day, you want to look at mature cells because you have no control otherwise. In fact, in the UK recently, there was an unfortunate situation with a colleague in ENT who actually did tissue engineering of the bones up towards the throat. And they turned into, the cartilage, it turned into bones, so the phenotype changed. At the end of the day, what you're trying to do is take a patient, take a biopsy, and then expand the cells. So let's look at the urinary tract. The first thing to say is you can't actually bioengineer something if you don't understand its normal function. And that really applies to structures such as the kidney. The bladder, for the non-urologist present, is a very complex organ. Whilst, of course, if you're dealing with conduits such as the urethra, then that's much easier. The ureter is equally difficult because it has intrinsic migrating motor complex, which you can't tissue engineer. So the kidney, if you actually look into it, there are artificial kidneys which are basically ones which are just doing filtration. And of course, the principle of this is that of dialysis. And if you actually look at it, people have tried to tissue engineer the kidney, but they can't because of the complexity of the cells and the interactions involved. It's not just growing a cell type. And you can see there's been an incredible amount of research in this area, the conclusion of which is you can't do it yet. Let's look at the ureter. As urologists, we often have to deal with ureteric problems. The middle part of the ureter is a particularly difficult area because of blood supply, and you can't just join it onto the bladder. And in these complex situations, just using a piece of bowel doesn't work. You end up with hydronephrosis, distension of the upper tract. You end up with metabolic problems, and autotransplantation is one option. ideally people would like to be able to tissue engineer something, but you can't mimic the migrating complex, which is why you end up with dilatation of the upper tract. What about bladder substitution? There was a well-publicized paper in The Lancet. There's a group in Winston-Salem in the States, had a lot of funding from the US Army, 300 million as a conservative estimate, Tony Attali and his group. And unfortunately, nothing has come out of that in the field of urology. They produced this paper in The Lancet about bioengineering the bladder. If you look at it objectively in these children, because he's a pediatric urologist, with neuropathic bladders, where you appreciate the problem is high pressures in the bladder, they actually only produce success in 30%, 60+% of the children had a failure, and the ones which succeeded were the ones where they actually used omentum as a substrate, and in fact they were just putting a patch on. A very expensive way of not achieving what they aimed to do, and in fact they had to be reoperated on too. So basically, why is that? Now, unless you're a urologist, you may not appreciate that the bladder is quite a complex organ. The urothelium has a metabolic rate 4 times that of the detrusor muscle. You have interstitial cells, which were described by Cahal in the rectum and the bowel many, many years ago. They've only been rediscovered by a colleague working in Belfast, Karen McCloskey, has done a lot of the work on this in the last 15 years. Now, you may think that the target of functional treatment for the bladder is the muscle. You're entirely incorrect. The drugs do have an effect on the muscle, but the target is the sensory component, which is what drives the disorders, the storage disorders. So you can see it's a very complex structure, the bladder. So you might be able to produce an epithelium, but if you look at the epithelium in the bladder, it has non-neuronal release of neurotransmitters. Sitting there, as your bladder fills, you're getting non-neuronal release of neurotransmitters. So you can see the alligator in the swamp with this is that you can't actually do it. And you might as well face that. Until we understand the exact issues with the tissue, you can't regenerate it. What about the urethral strictures? This is an area very dear to my heart, and tomorrow morning I'm doing a masterclass on urethral surgery, and this is something I've spent most of my career working on. And the problem in the urethra is ischemia of the corpus spongiosum, ischemic spongiofibrosis. So it's a blood supply problem. And of course, as urologists, we often deal with a particular condition, lichen sclerosis, which affects the epithelial cell type in the urethra. It never goes proximal to the distal sphincter mechanism, because then you get onto transitional cell epithelium. And of course, therefore, we're dealing with just a tube up to the sphincter. So ideally, you can actually deal with this by tissue engineering. In the last 20 years, we've been using oral mucosa because it's a wet tissue. People seem to think it was described from Great Ormond Street in the 40s, but in fact, if you look in the literature, it's described by a Russian colleague in 1890, and he died in the Bolshevik Revolution. The papers are all there, animal experiments, human studies, etc., but in Russian. So, can you bioengineer oral mucosa? Well, it's a serendipitous situation. I went to a lecture in the university, and my colleague, Sheila McNeil, had actually been the first in the world to bioengineer skin. So I thought, why not bioengineer oral mucosa? Because sometimes I have to put in 17 to 20 centimeters of oral mucosa, and it's quite difficult, both sides of the mouth and the bottom of the tongue, to get that amount of tissue. So, within approximately 9 months, working with her, we bioengineered oral mucosa from a 2 millimeter biopsy. You could end up with 20 centimeters. The problem, of course, and the devil in the detail there, is the matrix that you're putting the cells on. We're using allografts from the blood transfusion service from cadaveric tissue, but of course, still, even though it had been treated, there were still antigens present. We went in with ethics approval to patients undergoing 2-stage urethroplasty, so you could observe it, and 2 out of the 5 got quite a bit of fibrosis, 3 did quite well, and have continued to do well. But the problem is you need a type A laboratory, it's highly expensive, you can get it for free out of the mouth for most patients, and at the end of the day, you have a window of opportunity. Your operating list gets cancelled, you lose all of that. So we decided it really wasn't feasible. Unfortunately, some colleagues in Germany decided to commercialize a similar approach, didn't bother with the animal experiments and went straight into man. As I mentioned yesterday, the results have been dismal. So you really should, if you're looking at guidelines, carefully study things before you go any further. Another thing which people are talking about at present are cells, just putting cells in. Of course, that's totally ridiculous if you think of a stricture where you've got ischemia, putting cells down, because of course they won't grow and you've got no control over what they differentiate into. Remember that cells can change into different phenotypes, as I mentioned earlier, talking about the cartilage up at the level of the peritracheal area. So certainly it's feasible, we can do it, but at the moment, unless we've got decent biomaterials, you can't. Another area I deal with extensively is incontinence, which obviously is a major problem in women, and certainly if you look at the guidelines that we produce, you're dealing with the sphincter. Now remember, for the non-urologists present, that the urethra in the female is sphincter active. It's akin to the distal sphincter in the male. Men are lucky, they've got a bladder neck, which is the reason the human race goes forwards, because it prevents retrograde emission of semen. You've got the prostate and you've got a distal sphincter. Now that distal sphincter is akin to the female one, and where continence is dependent not only on the sphincter, but the submucosa, the periurethral tissues and the pelvic support. People have tried putting injectables in, and the traditional injectables are not particularly effective. There's a new one which is called Bulkamid, which is a gel suspension. The initial results look reasonable, but at the end of the day, it's very serendipitous if you get the injections in the right place. So what you're dealing with incontinence in an individual lady is an intrinsic sphincter deficiency, which occurs in many, or hypermobility of the pelvic floor, where the urethra falls outside the pressure zone of the abdomen. And any individual has a combination of both. So, if you're looking at tissue engineering, can you actually do something about this? At the end of the day, what you need to do is to be able to provide an alternative which is going to be effective. If you look at this data from Scotland, you can see that injectables, you can see the second row down, had a much higher cost, although it seemed to be an easy operation, a lot more operations and readmissions. So in the long term, just an injectable by itself, or tissue engineered one, is not going to be effective. There's also been some sad stories. Work taking striated muscle from Austria, fantastic initial data, using ultrasound-guided injection into the sphincter, and it seemed very impressive until, unfortunately, they produced results like this, and fraud was involved. They were all, unfortunately, the papers were all withdrawn, and unfortunately, there were consequences for the individuals involved. Because even if you inject cells, and striated cells, for instance, into an area, can you innovate them? Yes, you can innovate them. But is that functional innovation? So the cells you've injected sitting in a urethra actually can relax when you want to pee. Simple matter. Of course they can't, because they haven't got a link up to the brain. So it may be an expensive bulking agent, but it's not really feasible. So what about sphincteric weakness in more detail? This is a topical issue. We often think as surgeons in a static situation on the operating table. But dealing particularly in functional urology, of course you've got a patient who's moving around, and particularly a female patient, where basically the pelvic floor is an important component, because that's what's supporting the urethra and keeping it within the intra-abdominal pressure zone. And we certainly know that with increasing age, there's a change in the collagen in the pelvic floor in both men and women, but of course in women, a particularly significant problem. We also know from general surgery that polypropylene's been used initially for hernia repair, the Liechtenstein hernia repair, and many others, and caused major problems when used as a mesh. That led on to the AMET classification of a type 1 agent. I'll show that in a moment. So if you're putting a sling in, and this is something which came to the fore, as I mentioned last night, with the TVT procedure or TOT procedure, you no doubt have come across, which has now been banned in the British Isles, following on from marked patient pressure. You can see that polypropylene is very effective, which is the component used for those slings, because it causes an immense fibrosis. but it's a rather rigid material. It sits around. Over the years, you may have seen, if you're a urologist, xenografts, animal, bovine tissue being used, porcine tissue, allografts, cadaveric tissue. They were all marketed, and they all failed. And there are no papers to say they failed, but of course, logically, if you think about it, it's foreign antigen. And if you reoperate on these patients, you don't even have a scar. And if you're aiming to produce a fibrous scar to support the urethra, no surprise if you're putting the foreign material in. Of course, autografts, effective, and for the last 30 plus years, I've been using autografts with an autologous sling put in loosely for patients, and a third of my patients, when adequately counselled, choose that over a synthetic mesh when we're allowed to do them. The trouble is that the material that you look at has to be looked at carefully. Polypropylene is an agent which is macroporous when it's spun accordingly, but unfortunately is the wrong material. I showed us this slide last night for those who are present, and this is what happened in the field based on a series of 200 patients. All of this was introduced and for prolapse, and the consequence has been multi-billion-dollar lawsuits in the States and a continuing problem in my country and across Europe with lawsuits. And indeed, if you actually look at it, a lot of this has been due to misunderstanding, and as we heard earlier in the meeting, failure to counsel patients appropriately and explain to them, like any surgical technique, there's a downside. On the left-hand side, you see a sling erosion, which is usually due to surgical inappropriate surgery, not leaving a vascularized vagina behind, dissecting it, and this is due to surgical misadventure, putting the sling in the wrong place. At the end of the day, what you're trying to deal with is avoiding this situation, because a number of companies have gone bankrupt over this, and Johnson & Johnson, for instance, have had to pay out, at a conservative estimate, over $5.5 billion so far relating to this issue. If you look at this data from the United Kingdom, you can see that there's a perioperative complication rate, which is not that insignificant, but equally what you'd expect with any procedure. And there is a complication rate with mesh erosion, as you can see from 2 studies there. So this is something that we tackled, and I'd like to show you how I think you can objectively look at using the principles of tissue engineering. You want to decide what the material is you want to use. Obviously, a patient's own fascia you might consider to be the gold standard, because at the end of the day, if you take fascia out, it's a crude form of tissue engineering, like much surgery. It's got no blood supply, and what you're taking is matrix with cells on. You're implanting it, it's picking up a blood supply, the fibroblasts are proliferating and producing a scar. I've already mentioned the importance of the mobility of the situation, and when we carry out this work, we always use a dynamic testing situation to test out the material. A simple way of doing that is using a bioincubator with a balloon on. You spray your cells on, and this goes 24 hours a day up and down, contracting this balloon, and you can then see what happens. And when you stimulate cells, they produce collagen. In a static situation, they don't to the same extent. So what you need to know, which scaffold material, which cells, and how do the cells interact with the biomaterial, and what inflammatory process occurs as a consequence of that. You want to then look at the integration of whatever you're doing into tissues. And then you want to see what tissue remodeling occurs ultimately. We looked at 2 different proposals. One is producing a fascia-mimetic tape akin to polypropylene, in this context polyurethane, which is used for heart valves, using this as a microspun material, producing the same characteristics as mesh when looked under the electron microscope, scanning electron microscope. Alternatively, a biodegradable agent which gets absorbed completely. And we've looked at polylactic acid, which comes from maize, broken down into carbon dioxide and water. Certainly the problem, as I've already mentioned, with polypropylene is it's stiff and inelastic, and also it produces quite a significant consequence of the implantation, in the sense that there's a lot of inflammation present. So really what we wanted to do was develop a fascia-mimetic material, whether it was one which was non-absorbable or absorbable, and to choose approach which would be effective, obviously. We need to therefore move forwards and look at ways in which we could evaluate this most effectively. We looked at in vitro mechanical testing in a dynamic situation. We looked at the interaction of the cells with the material, and we looked at in vivo animal models which have been used, in particular a sheep model from Leuven, where polypropylene has an erosion rate of around 40%. So in other words, a hard test for an agent. Also, estrogen is a very effective treatment in the female vagina, particularly post-menopausal. It improves urgency and reduces urinary infection, but also we found by looking at this carefully using an egg preparation that you could actually show it actually improved vascularization. So you've adsorbed this onto material, you get rapid neovascularization. And we also have used advanced surface scanning with electron microscopy, and then interacted this using molecular approaches looking at T cells. And of course, we've also produced a 3D model, which has now been widely used. Microspinning material now, this is quite an advanced science, can actually produce materials which look very like fascia and which are representative of that. This is the type of testing where you can stretch tissues, and you can see here that polypropylene fails when it's stretched. It becomes rather brittle, and the components that are produce a dense inflammatory process, which causes a pain in many patients who present with this. And indeed, you can see this if you look at it under the microscope, and you can also look at the polymorphonucleoleucocytes and the fibroblasts relating to the mesh in more detail. What we've done, of course, in vivo is to be able to look at this more effectively, and we've reported this in various models, in particular in the rabbit and the sheep model I've alluded to. This is using the chick chorionic membrane, which basically looks at vascularization, and you can see neovascularization with estrogen is much more rapid. So really what I'd suggest to you, whilst it looks sexy, tissue engineering, it's certainly feasible. As long as you set the parameters at a level at which you can actually achieve. If you try and do the impossible, it'll never work. If you go through this logically, then you can actually produce a material, and polyurethane is now going into clinical development, a patent held by the university and my trust. I have no commercial interest in this. And certainly, I think this will be potentially more effective for patients. You need to develop tests, and many of these tests are ones produced at the bioengineering department in Sheffield, which is one of the best known in the country because of the history of steel production and so on, and they have a good university department on this. I can't take any credit for that. I'm a simple surgeon, but I'm working with scientists who know what they're doing, and so far 15 urologists in training have gone through this process and got degrees out of it, research degrees out of it, which is very important. And you can see that what we have managed to do is to hopefully to produce something where you can adsorb estrogen, which is beneficial to women, onto the material, but also have positive results. We're also advancing the situation with polylactic acid. You can actually produce it with a mechanical profile, which looks like fascia, and by using fat tunnels, you could potentially, in the future, still not produced yet, have a material out of a packet, liposuction in the morning, and the cells can actually be placed onto the mesh and implanted. And certainly the initial work that we're doing looks very effective in that context. So certainly, which scaffold material? Polyurethane and polylactic acid. What are we actually doing with the cells? That's still being assessed in great detail using molecular markers for the various types of inflammatory cell. What can we improve the host integration? We feel we have by the microspun technology and the implementation of this, and how can we achieve good long-term mechanical outcomes? Of course, that is the aim, and time will tell. I welcome you to the EAU meeting, as I mentioned last night, for the urologists present, either in person or virtually. Thank you for your attention.